Now it's a pleasure to introduce Dr. Hadi Abu Hantash, Professor of Cardiology and Interventionist Cardiology, University of Jordan, who will give us a talk on revascularization in acute coronary syndrome, particularly in cardiogenic shock.
Thank you very much. Let me first thank the GIS board for the kind invitation and congratulations for the success of the meeting so far. Chairman, esteemed panelists, I was given the task of talking about closing the gap on cardiogenic shock in acute coronary syndrome. A tough task indeed. But when you look at what's happening in cardiogenic shock in the past 20 years, the cases are increasingly becoming more frequent. And in spite of that, the mortality, the in-hospital mortality is staying just about 50% plus. So we're not really doing a lot as much as we want in that aspect. This is a slide which I personally think it's awakening for all of us. When those patients present at hour 10.2 hours after the 0 time of presentation, almost 50% of those patients will die in the hospital. That's really warning. The warning part is important, and the most important part is you have to take action as quick as you can. Now, cardiogenic shock, yes, ischemia and opening an artery is an important factor in treating it. It's a very complex pathophysiology if you look at the left side and the right side, which culminates on decreased ejection fraction and diastolic dysfunction and poor outcome. So it's not as simple as opening an artery. In the shock trial, which came 10 years ago, it's important just to stop for a minute talking about it. There were a lot of patients who have multivasal disease, which goes hand in hand with a lot of other data coming from coronary syndrome patients, whether acute or chronic. Now, the incidence of multivasal disease in the shock patients, in the shock trial, in the randomized arm was 87%, in the registry arm 79%, quite high. And in the shock trial, 20% of the patients had left main coronary disease, and 64% had a triple coronary artery disease. We know the presence of multivasal disease in any acute coronary syndrome, whether ST elevation or non-ST elevation, leads to poorer outcome than patients who have single vessel disease. So what are our revascularization options in cardiogenic shock? Should we open the culprit only, or should we do the culprit only and then stage revascularization whether pre-discharge or soon after discharge, or subjecting the patient to coronary artery bypass surgery, or there's a big question mark, should we do an immediate multivasal PCI? The shock trial itself, which came 10 years ago, shed lights on randomization of patients early on for emergency revascularization versus initial medical stabilization, including using intra-aortic balloon pump in both arms. It did teach us that early revascularization leads to a better outcome, whether it's 30 days, 6 months, and 12 months compared to initial medical therapy. So initial medical therapy will not work for our cardiogenic patients. You have to revascularize those patients. One important aspect also of the shock trial, it gave us some interaction with age, and it told us that patients who are below 75 years old, by looking at the interaction p-values, do seem to do better than older than 75. And that's an important something to keep in mind. In contrast to all the data, here's a meta-analysis of doing complete revascularization in ACS patients. I don't want to go through all of this data, but we all know that favoring multivasal PCI in non-cardiogenic ACS patients is quite evident. So that we're not going to discuss that today. The thing is, in 2018, when we looked at multivasal PCI in cardiogenic shock from registry data, it really threw a light of warning that maybe the culprit only vessel PCI in cardiogenic ACS patients should be the way to go. And with that, the culprit shock came out. The culprit shock trial, which you're all aware of, it treated only the culprit. Let me tell you this, and I'd like to hear the panelists and the chairman tell me, what do they mean by culprit lesion compared by culprit vessel? I was like reading this right, left, right again, and I was trying to figure out what are they talking about. Is it the culprit vessel or the culprit lesion? If you have a mid-LAD total occluded big clot in it, proximal LAD 70%, you will leave the 70% and open the culprit lesion? I don't know. I'd like to hear from the panelists about that. But anyways, for the primary study endpoint in the culprit shock trial, it was very obvious that all-cause mortality or renal replacement therapy is better with culprit-only lesion opening compared to the multivessel, and the all-cause mortality is also better. And the renal replacement therapy definitely is better when you do only the culprit and not do multivessel PCI. And you can tell that the divergence of the curve is very early on, and it catches up later, up to 3 years of follow-up in terms of total mortality. The all-cause mortality subgroups showed that the culprit PCI and the culprit shock trial, whether you look at STEMIs caused by anterior or non-anterior infarction, non-STEMI or STEMI, patients who had no diabetes seem to be doing a lot better than the patients who are diabetic. Probably it's related to the multiplicity of the vessel disease and the diffuseness of the disease in diabetic patients. Now, we all know, and that came out from tons of trials before, multivessel acute coronary syndrome, PCI, the major factor which leads to better outcome is the 1-year repeat revascularization, which is definitely better in the patients who have a complete revascularization, because you are attacking more than one artery at the same time. However, there is something which comes out of this positively, that the incidence of heart failure in patients who had multivessel PCI is less than the people who had culprit PCI, which I think pathophysiologically makes sense too. So this is from the British Columbia registry. It really duplicated the culprit shock trial in terms of teaching us that it's better to do culprit rather than multivessel PCI, but it suggests, because of the early divergence and then the catch-up after that, after 1 month, that it all occurs in the immediate multivessel PI period. It's acute and transient while they are in the hospital. Well, in the setting of cardiogenic shock, does it matter which artery, if you want to do multivessel PCI? If it's an right coronary inferior, you open it up. The LAD has a high-grade disease. Do you have to do it? Well, I think this is a particular subset of patients where a lot of people would say, do not do it, do not do it. Do not touch the left main or the LAD in that setting with patients with cardiogenic shock. We don't talk a lot about Cabbage. Cabbage is a good alternative. It carries the same mortality as PCI in patients with shock, and that was in the shock trial too. In the shock trial, the patients who underwent Cabbage were the ones who had severe triple vessel coronary artery disease, left main disease, and failed percutaneous intervention. So Cabbage is a good alternative, actually. This is from William O'Neill, Piedmont in Detroit. They presented this in the SCAI last year meeting. I highlighted that in red. What did the registry show? 71% of patients had mechanical circulatory support implanted before the PCI. I think that's a very important item. Why is that important? Because if there is any data which might change the guidelines, it will come out of cardiogenic shock usage of mechanical circulatory support early on before you do the PCI in order to get a benefit from doing non-culprit PCI in the same setting. Now, the problem is we use a lot of inotropes for our patients. The more inotropes you use, when you look at the lower figure, the poorer the outcome, which might be because they are the sickest patients anyways. But instead of using more inotropes, think of mechanical circulatory support early on in your cardiogenic shock patients. The revascularization guidelines 2021, they really made it so clear shock patients are the best patients to have a good heart team working together. In patients with STEMI and who have cardiogenic shock, PCI, when it's feasible, is better done, and Cabbage is a good alternative. As I mentioned, doing non-culprit PCI until this particular moment with cardiogenic shock patient is still a class 3. You're not supposed to do it. That goes also for ST elevation and non-ST elevation myocardial infarction. Again, this is a good outline how you should go. Let me tell you something. The intra-aortic balloon pump, which most of us is the only mechanical circulatory support we have, it still works, especially in patients who have mechanical complication like VSD or mitral regurg. Allow me less than 20 seconds, just 20 seconds. Okay, can you put the last slide? This is my, I went really good. It's just 20 seconds.
The slide is there.
Yeah, okay, good. So what is my conclusion? In patients with acute myocardial infarction and cardiogenic shock, a strategy of culprit vessel PCI appears to be associated with lower mortality. That's what we have in 2022. Culprit vessel PCI was a preferable revascularization strategy, specifically in patients aged below 80, male, non-diabetic, and those presenting with STEMI. Multivasal PCI may be considered. It's just a maybe, please. I'm not recommending that now. In selected patients and in the setting where the non-culprit is a circ or an RCA, not an LAD or a left main. PCI of the non-culprit LAD disease was associated with higher mortality, as I outlined. And I think the best message also, early usage of mechanical circulatory support leads to better ACS cardiogenic shock outcome and might enable you to safely do non-culprit PCI. Thank you very much.
Thank you very much, Dr. Hadi, for the very nice presentation and elegant presentation. So if I take one comment from our panelists, dear panelists. اتفضل دكتور نايف.
Yeah, thank you, Dr. For excellent presentation and extensive review. I think one of the major messages here is to do the minimal work in case of cardiogenic shocks just to achieve TME3 flow or better flow, and to take the patient from the cath lab in good condition, or at least without arrest. So I think doing additional or multiple steps or complete work in case of cardiogenic shock, including bifurcation stenting or multiple ballooning, will complicate the scenario. And another message also is to send the patient immediately to a shock center, irrespective of time of delay of PCI. So do you have any comment about this, Doctor?
This is a great point. I mean, when you do cardiogenic shock patients, you open the culprit, I would say vessel, not not lesion. I'd like you to comment on this, actually, because I was trying to figure it out. I read the culprit PCI. I don't know, Hani, if you agree with me. I mean, why did they say the culprit lesion? They did not say culprit vessel. And then they use the terminology back and forth. You know what I mean? Yeah. Multivasal PCI, but they say culprit lesion PCI rather than culprit vessel.
I think they mean to treat or to fix the unstable lesion only. Some coronaries, they might have multiple but stable lesions. Just treat the unstable plaque or plaque rupture lesion related, do the minimal work, and take the patient out of the cath.
So allow me, Chairman, to say something,
Sure.
Hani, and Hani might even comment on this. So like what I said in my lecture, what would you, I mean, you take a patient with massive anterior myocardial infarction, cardiogenic shock, blood pressure is 70, mid-LAD, big clot, totally occluded, proximal LAD 70%. You take your gloves out, you don't touch it. I'm trying to figure it out. What do you think, Hani?
Yeah, if I understood correctly, sorry, there's a little bit of noise regarding the culprit vessel and culprit lesion, because we use angiography only, and we just rely on the angiographic feature that this is the culprit lesion. But I agree with you, there are multiple culprit lesions anywhere else in the circulation, including the culprit vessel itself. The treatment is what we do, is medical management of the whole milieu of the culprit vessels. Regarding whether I would do anything. I would adhere to the data, and which is compelling, you know, that culprit vessel only. When would I do complete revascularization? I agree, I stay away from the LAD because it's a more complicated, and I really minimize if it's a simple lesion, which is very unlikely in this setting because they all have extensive coronary artery disease, and remember, there is another day, the mechanical circulatory support, to my mind, is in agreement with you. It could be a game changer. Thank you.
Thank you very much. اعذروني بس I'm short time, but I promise you after the mechanical support, I'll allow for more discussion. If you allow me, I'm sorry, because I'm really short in time. Thank you very much, Dr. Hadi, for the nice and elegant presentation.